Well, a warm welcome to today's talk. It's Sunday evening, the 7th of November. Now, I don't want to be melodramatic because I get told off for that, but this one really is a potential game changer because this new antiviral medication from Pfizer, they are claiming at the moment that there's an 89% reduction in hospitalizations and an 89% reduction in deaths. So that means if this was rolled out globally, if it's affordable, this could be a massive thing all over the world. Really could. So we'll be looking at this. Now, this is the paper here. Well, it's a press release, actually. Now, I've put the link in, of course. If you want to read it, it is actually fairly intelligible. It took me about sort of maybe two and a half hours to work out what it was getting at altogether. So quite accessible, really. But of course, it's science by press release, which of course we're not that keen on. But anyway, let's just give a quick bit of background before we look at the detail on this new antiviral. Now, protection from hospitalisation, the story so far. So what these are oral medications. Basically, they would be given as soon as someone becomes symptomatic. And they would be given to prevent people from deteriorating and needing hospitalisation and therefore hopefully preventing severe illness and preventing death. So that's a really good idea, of course. So that's what it's about. Now, Molnupiravir has already been approved by the MHRA, the regulatory authorities, the Medicines and Healthcare Products Regulatory Agency in the UK. And the government were effusive about how brilliant this is. The antiviral was found to be safe and effective following a stringent review of available evidence, that they are saying in this direct government paper. Public domain data, though, which concerns me, we have a Merck press release from the company that's making it. That's all we have. And to me, that is not enough because there are theoretical reasons why this drug could have side effects. And we need we need all the world's scientists to peer review this data before we are so effusive in our praise, certainly on this channel. As well as that, it's $700 for a 5-day course. At least that's the price in the USA. The UK price, of course, we don't know. We haven't been told. And it's just under a 50% reduction in, I think I've spelt that wrong, in deuteriation. Okay. So it prevents about 50% of people going to hospital, which of course is great. So that's that one. But as we say, waiting for peer-reviewed data. Because, we're dealing with basically a new drug here. That there are reasons why it could cause problems. Merck and the government are saying it doesn't, but we want the world scientists to agree with them first before we go head over heels with that one. This one, on the other hand, Fluvoxamine that we looked at a few days ago, this is part of the Together trial. Public domain data here is a peer-reviewed trial in the Lancet, which of course is much more up our street, links there. Adults with a risk factor, so age, heart disease, renal disease, immunocompromise, that they were given that as soon after symptoms developed as possible. This is $4 for a course. So not $700, $4 for a course. 32% protection against hospitalisation, 32% protection against death. It's approved by the Food and Drug Administration and the authorities in the UK and round about the world as an antidepressant, of course. It's one of the selective serotonin reuptake inhibitor antidepressants. So doctors already seem to be prescribing it off-label using their clinical judgment, according to that article there, at least in the States. And given that Fluvoxamine is a known drug with a known safety profile, I would be more than happy to take a 10-day course of it without too much hesitation. So that's that one. The next one that we've talked about on this channel is Ivermectin. Now, Ivermectin is actually part of the Together trial. The Together trials actually said Ivermectin is not effective, but they haven't released any data yet. So I'm not going to risk talking about that further at the moment. We'll wait and see what their data says, although on this channel we have looked at data. Let's just say we've looked at data on Ivermectin before, but we'll leave that there for now. So this is the new trial here. Pfizer's novel COVID-19 oral. Now this is the key thing. All these medicines that I've talked about here are all oral. So the Fluvoxamine is oral, the Molnupiravir is oral. You just take a tablet. You don't have to go into hospital or a special facility as you do with the monoclonal antibodies, which we know are effective, but they have to be given intravenously. So these could be given to anyone who's considered at high risk of deteriorating or being hospitalised or dying, basically as soon as they get symptoms. And it looks like the sooner after symptom onset they get these medications, the better. But more detail on that in a minute. So this is their candidate: reduced risk of hospitalizations or death by 89%. I mean, this is just wow. This is a blow your socks off number. Way better than Molnupiravir. Way better than Fluvoxamine. Although we don't know how much it's going to cost yet, so we'll just put a question mark on that. How much is Pfizer going to charge? My suspicion is it will not be cheap, but we will see. We might be pleasantly surprised. Public domain data so far, Pfizer press release. Well, that's it. That's all we've got at the moment. So this is what we've got at the moment. But I think we can assume that what's in it is valid. They're not going to make things up in a press release. Paxlovid, I guess that says Paxlovid. Now, this is the experimental name of the drug. Now, it's called Retinovir here. Now, this confuses me because Pfizer is saying this is a completely new drug, but Retinovir is an antiretroviral drug that we've been using for HIV for years. So is this Retinovir or is it a different molecule? I think it's a slightly different molecule. They must have jiggled around with it a bit. So I guess it's based on Retinovir, but that's the experimental name of the drug. And it's now called Paxlovid. That's the trademark for it. Found to reduce the risk of hospitalisation and death by 89%, direct quote, compared to placebo in non-hospitalised but high-risk adults with COVID-19. So again, much in the same way as they did with the Molnupiravir trial, they've taken patients who are at risk of deteriorating and they've followed them through. So the follow-through here is through to 28 days. Now, headline here, Paxlovid group, no deaths, placebo group, 10 deaths. Well, that would be more than an 89% difference, wouldn't it? But that's what they're saying here. Pfizer plans to submit data for regulatory authorization ASAP, of course, and this is going to be everywhere. So this press release doesn't say this. It talks about the US FDA, but I think we can assume that Pfizer have applied for licensing agreements everywhere, at least everywhere that can afford to pay for it. So it's phase 2/3 EPIC-HR, so evaluation of protease inhibition. So this is a protease inhibitor for COVID-19 and in high-risk patients. So that's the name of the trial. So it's a protease inhibitor. Now, I've been trying to think about this. I'm pretty sure that I first used protease inhibitors way back in '96 in India as an antiretroviral treatment. I think they came out in '95, protease inhibitors. So what protease inhibitors do is, to make a new virus, the virus needs proteins, particular lengths of particular proteins. And to break long proteins up into shorter proteins, it uses proteases, enzymes that break down proteins. So these drugs are protease inhibitors, so that the protease inhibitors are inhibiting the proteases, so the proteases can't chop the proteins up into the right length, so you end up with proteins that are too long to be able to make the virus. So the basic building blocks for the virus are denied the virus. That's how these things work. Protease inhibitors. Yeah, and I'm pretty sure it was 1996 I first used these. So that is pretty good safety profile. So I actually feel much more comfortable about this personally because we've been using it for all these years, rather than Molnupiravir, which has not been extensively used before. This is a familiar, if it's not an exact molecule, it's a familiar group of drugs. Just like Fluvoxamine is a familiar group in the selective serotonin reuptake inhibitor category that I've taken myself and many others have taken. So this anyway, but getting back to the Pfizer study, randomised double-blind study of non-hospitalised patients, adult patients with COVID-19, high risk of progressing to severe illness. Now, this is what you call a scheduled interim analysis. So like halfway through the trial, or a bit more than halfway through, they stop and say, well, how are we getting on here? If it's killing people, they would stop the trial. If it's curing people, they would stop the trial because it would be unethical to continue. 89% reduction in the risk of COVID-19 hospital deaths from any cause compared to placebo. So very efficacious. And as a result of that, as we'll see, the trial was actually stopped because given that people were dying who received the placebo and people were living who received the Paxlovid, it would be unethical to continue giving people a placebo. Now, more specifically, in patients treated within 3 days of symptom onset, so within 3 days of symptom onset, in the Paxlovid group, so this is the Paxlovid group here, 0.8% of patients were hospitalised, 3 out of 389 patients, no deaths. So that's one group there. Here's the placebo group to compare it to. So there's the placebo group, because we like to compare groups with groups, is exactly what we do. There's the placebo group, 7% of patients hospitalised, that was 27 out of 385. Tragically, 7 subsequent deaths. And the probability that the difference between the Paxlovid group and the placebo group arose by chance was P equals 0.0001, which is a 1 in 10,000 chance that that result could arise by chance. In other words, we're pretty certain that this is a genuine difference between the two groups, greatly in favour of the Paxlovid group. I mean, that is a clear-cut slam dunk as far as clinical trials are concerned. It doesn't get much clearer than that. So it's looking remarkably amazing, really, at the moment. In patients treated within 5 days of symptoms, 1% of patients in the Paxlovid group were hospitalised, 6 out of 607. So clearly, well, not clearly, but this is intimating quite strongly that the earlier the treatment started, the better. Placebo group, it was 6.7% of patients hospitalised or died, 41 out of the 612. 10 subsequent deaths, I'm afraid, and again the p-value 1 in 10,000 that this result arose by chance. So again, we've got the comparison between the two groups there, and it's clear this is what clinical trials are all about, comparing the placebo group with the intervention group, and the result is clear. So at the recommendation of the Independent Data Monitoring Committee and in consultation with the US Food and Drug Administration, Pfizer will cease continued enrolment. So basically the Data Monitoring Committee, which is independent and genuinely independent, no cynicism there at all, and the FDA, US FDA, they said, no, we're happy with this, you don't need to carry on experimenting. This data is good enough. And given the numbers we've got on those p-values, it is good enough. I agree completely. In fact, it's really quite impressive due to overwhelming efficacy of the results demonstrated. Now, they'd got as far as enrolling 1,219 adults, and they were scheduled to do 3,000. Now, if the result had been more subtle, you might have needed 3,000 to differentiate if there was a benefit or if there was an adverse effect. But the effect is so obviously massively beneficial that 1,219 patients were more than enough. These patients were recruited in North and South America, quite a few from the United States actually, Europe, Africa and Asia. So international cohorts, which is always good to see. Enrolled individuals all had a laboratory confirmed diagnosis of PCR diagnosis confirmed. They were all definitely infected. They all had early mild to moderate symptoms, which of course virtually everyone does at the beginning. So this is not really excluding many people, which is exactly what we want, of course. And they had at least one underlying comorbidity or increased age. Randomised 1-to-1 or placebo, orally every 12 hours for 5 days. So as simple as taking a pill, which is what it is. Now, safety. This is crucial. Now, with the Molnupiravir, there is a reason, and I don't know yet. I stress I don't know, and I stress that the regulatory authorities don't seem to be worried about it. But there's a reason why that this might cause problems a few years down the line, because it's got the potential. Well, we know it works by mutating viral RNA, and I want thorough reassurance that it doesn't mutate human RNA and DNA before I can comment further. And we simply haven't got that data yet. We're just at the stage of taking people's word for it. And there's a theoretical reason why I'm uncomfortable with that. The antidepressant one, the selective serotonin reuptake inhibitor, I'm more than happy with that. I've taken a course. We've been using them for years and years. Millions and millions and probably 1 billion people around the world have taken them, more than 1 billion. And likewise with this new drug, we've been giving them out since 1995, these protease inhibitors. So I feel pretty comfortable that there's nothing that's going to come back to bite us in the ankle in years to come with this. So what I'm not worried about is the longer term side effects. So what we need to look at is the shorter term side effects. And that's what this data gives us information on. Now, they got safety data on 1,881 people, so slightly more than the number of people in the trial. So more people had obviously taken the medication than actually reported the results. Treatment emergent adverse events. So the Paxlovid group, 19% of people complained of adverse events in the trial. The placebo group, 21% complained of adverse effects. Now, people are always asking me, how can, if placebo is just a sugar pill or just a pill that contains nothing active, how on earth can people get any effects from it at all? Well, the answer is that they can get beneficial effects called placebo effects. Or if they believe that they're... Of course, these people don't know whether they're taking the active drug or not a placebo. They know they're on one or the other. They don't know which is which. But if they're taking the placebo, they know there's a 50% chance they're taking the real drug. And they can actually develop side effects from that because they believe they could develop side effects. And this is called the nocebo effect. So it's like an inverse or negative placebo effect. So the placebo effect makes people better because they believe they're going to get better. The nocebo effect makes people feel worse and generates clinical symptoms because they believe that they might. So that is what is happening there. So we see that, again, very, very nice comparison. This is what clinical trials are all about. We actually see no real significant difference between the groups. Most of which were mild in intensity. So most of the people just carried on taking the medicine as a result of this. Nothing particularly to raise alarms there. Not surprising because we're very familiar with protease inhibitors. We've been using them for years. There are recognised side effects on fat distribution and things like that. But these are all well known and well recognised. Now, fewer serious adverse events in the Paxlovid group. Now, for serious adverse events, in the Paxlovid group, 1.7% of patients complained of serious adverse events. And in the placebo group, 6.6% complained of serious adverse events. So again, looks like quite a few people had a nocebo effect, but again, we see that it's not showing it's any more dangerous than placebo. In fact, that's indicating that it's, I would imagine, statistically significantly safer than placebo, which is a bit weird, but you know, in terms of getting the drug rolled out, it's a good sign. So that's good. Now, what about patients who had to discontinue use of the study drug due to adverse events? Well, the Paxlovid group, 2.1% of people who took it felt they had to discontinue because of side effects and adverse events. In the placebo group, 4.1% believed they had to stop taking it because of adverse events. They couldn't carry on. So again, straight comparison, and we see it's looking pretty impressively good, surprisingly good data. I know Pfizer themselves were taken aback by how amazing this data is. Of course, we want peer review, we want a lot more information, but so far... Right, just a few more things to round off. Pharmacology. Now, they say this drug's specifically designed, so that means it must be a variation. SARS coronavirus 2, 3CL. So 3CL is the subclass of protease inhibitors. So it's a bit like you turn up to your building site with lots of long pieces of wood. These are your big proteins, and you need to cut these pieces of wood to put them into a window frame to make your building. But someone's got hold of your saw and sabotaged your saw and made it all blunt, so you can't saw the pieces of wood up. Therefore, you can't fit them into the building. That's the same thing. These long proteins that are synthesized by the virus must be trimmed down into precise lengths to fit into the viral structure. The proteases that trim the proteins, the proteases are the saws or the knives or the scissors that trim the proteins. Take those away. The proteins are too long to fit into the virus. Therefore, you don't get viral replication. It's a well-known pharmacodynamic effect. So this is an enzyme that coronaviruses need to replicate, of course, to cut the proteins into the right length. Now, they're actually talking about co-administering a low dose of Retinovir, which is another one of these similar drugs, to help slow the metabolism of the new drug. Now, that's fine. Giving two drugs together is very common to have. We call this pharmacokinetic interactions. So that's quite common. It would prolong the half-life of the drug, meaning you can give a lower dose, which is fine. Inhibits viral replication at a stage known as proteolysis. So proteins, lysis means to break up, in other words, chopping the proteins up to the right length, and that occurs before RNA replication. Preclinical studies did not demonstrate evidence of mutagenic DNA interactions, which I agree with, and it's not that I'm particularly happy with these preclinical studies. What I am happy with is that I've personally been giving this drug out since, well, not all the time, depends where I've been working, but as I say, I'm pretty sure I first gave this out in 1996. So this is a drug we are very, or a group of drugs we're very familiar with. Now, includes most of the patients who took this were unvaccinated, but it includes some vaccinated patients who've had an acute breakthrough of symptoms and who also have risk factors for COVID-19, because we know that people that have been vaccinated, who are older or have comorbidities, or it's been a while since they've been vaccinated, we know that they're still at risk of breakthrough infections, which can result in hospitalisation. So it looks like it's good for those people as well. It could be prescribed more broadly at home to help at a home treatment to help reduce illness severity, which is good. Reduce hospitalizations, reduce deaths, as well as reduce the probability of infection following exposure amongst adults, they're saying. In other words, what they're saying is this could be used as a prophylaxis. Now, there's a trial that started in September that is looking at this specifically, and we haven't got the results from that yet. But if it's going to inhibit the formation of the virus, then someone who's going to be exposed isn't going to make the virus as normal. And if you can't make the virus as normal, you can't pass it on to other people, and they're not going to get the illness. So it's a prophylaxis as well, which means you could actually take an area where there was an outbreak and kind of put a firewall round about it by giving this medication to stop the spread, for example, of a new variant. This is how dramatic this could potentially be. So the prophylactic studies, the trial results should be out on that in a few months, but they are being done. Demonstrate a potent antiviral in vitro activity against circulating variants of concern. In other words, in vitro at least, not in vivo. So in experiments in the lab, it seems to work against all VOCs, which is good, as well as other known coronaviruses. So we haven't got SARS coronavirus 1 now. That's been eliminated from the world. But we do have a lot of common colds. We have 4 common colds caused by coronaviruses, so it might be potentially an anti-cold medication. And of course, we get a few hundred cases a year of the Middle East respiratory syndrome, which is very nasty, from camels, mostly in the Middle East. And it would be a treatment for that as well. And it would be interesting to see if this does have antiviral properties in groups of viruses outside coronaviruses. Don't know yet, but it will be interesting to find that out. I'm sure they're looking at that. Potential as a therapeutic for multiple types of coronavirus infection. Yeah. Okay, we'll just say a little bit about what the boss is saying. Chairman, Chief Executive of Pfizer. Today's news is a real game changer. Now, if all this checks out, I agree with him on this occasion. It is a real game changer. In the global effort to halt the devastation of this pandemic, I agree. These data suggest that our oral antiviral candidate, if approved or authorised by regulatory authorities, has the potential to save patients' lives. Given on what we've read today, yes. Reduce the severity of infections, yes. Eliminate up to 9 out of 10 hospitalisations from this data, yes. Fulfilling our responsibility to help healthcare systems and institutions around the world, he says, while ensuring adequate and broad access to people everywhere. Now, I'm hoping this is going to include people in Uganda, for example, who can't afford basically hardly anything, or they can't afford anything. I'm hoping this is going to include people in the very poorest parts of the world to whom $1 is a daily income. Now, if he means this, people everywhere means this has to be at a price which those people can afford, which means it needs to be priced in the cents, not in the dollars, tens or hundreds of dollars. We will see. But I'm going to give it a tick because I'm going to give him the benefit of the doubt. If he wants to come on and talk about that, he's more than welcome, of course. So there we go. It is a potential amazing game changer, really quite staggering. And as I say, I feel much more comfortable about, when you're talking about drugs, you always want to go with familiar preparations and things that you know about, drugs that you have experience with. Or if you can't have drugs that you're experienced with, at least drugs that you're familiar with the group of drugs. And again, with the antidepressants, with the fluvoxamine and with these protease inhibitors, we are already very familiar with them. So, and we know, how long is it since 1996? That's 25 years ago or something. So, we've already got 25 years of safety data, and it is pretty good. So, there we go. Pretty interesting and exciting, and interesting to see which way the regulatory authorities jump. If they jump fairly quickly, like the British authorities did with the Molnupiravir, that would be more understandable than I'm not quite understanding why the British authorities jumped so quick with Molnupiravir. But with this one, if regulatory authorities on both sides of the pond jump fairly quickly, I would find that much more comprehensible and feel much more comfortable with that. Sorry if I've gone a bit long, but thank you for watching.